So I'm a board certified psychiatrist and I've helped over 260 PMHNPs gain clinical confidence in their psychiatric diagnosis skills, treatment skills, and their patient outcomes, and actually improve their income as a result. So in this video, I want to cover why some doctors hate NPs. And so a lot of my students in my coaching community have wondered this too. Like, why is it that so many doctors seem to hate us or dislike us? And I first came across this concept, I remember I was in residency and we were discussing, all of us residents were getting together, we're discussing this patient case. And the patient was on Cymbalta, Zoloft, and Prozac, basically like three different SSRIs and SNRIs. And so I remember one of my co-residents raises his hand and goes, "So who's the NP that prescribed that?" That was my first exposure to that. And then ever since then, like every time I would see a patient with a subpar medication regimen, the consensus or the thought would always be that, okay, there must be some NP in the community who prescribed that. And as I began getting further in the field and working with NPs and other doctors, right, I realized that, of course, this is not true, but that was the perception. So if you're an NP, I want to make sure that at least if you felt this way, you understand where this is coming from, a doctor or psychiatrist side, why other doctors feel this way, and why I think that actually having NPs in the system can be a huge advantage for doctors. So the first thing that I want to cover, the first reason, is poor training. So obviously there's some NPs who are very good and function great in the system. But a lot of them, upon examining deeper, will say that, yeah, it's because I have X amount of years in this experience, or I was a psych nurse for like 10 years before. Nowadays, though, there's a lot of direct entry programs. There's online degree mill programs, and there's no residency. So it's just straight practicing after the schooling is done. And then, also the curriculum, non-real world curriculum. And this is stuff that all my students have complained about too. They'll be complaining about direct entry NPs. They'll be like they don't have the experience like that a lot of other people did who worked as a psych NP for 5-10 years, or psych nurse 5-10 years. They'll say that I went to a brick and mortar school. We had actual rotations. We didn't just do everything online. They'll say, hey, I did like a 1-year residency after my schooling. I didn't just jump straight into practice. They'll say our curriculum was good, but a lot of NPs don't have this. And so what happens is that a lot of doctors feel like that NPs don't understand this, and they feel like that they're being very arrogant in practicing. Like they're just practicing just to make money, and they don't really understand how quote unquote bad they are. Which is not true. The reason that we have so many NPs in our program is because they realize that, hey, the school system has failed us. The training system has failed us, and now we're not getting the education that we were promised to get and we're supposed to get. So that's why they seek out mentorship. But this is a reason why many doctors are not fond of NPs. The next one that you may or may not have thought about is burnout and resentment. So I remember experiencing this as a resident too. So imagine this, imagine you're a medical resident. You've gone through 4 years of medical school, age 22 to 26 at the minimum. And now you're $200,000, $300,000, $400,000 in debt. Then you get to residency where you're working 60 hours a week, 70 hours a week, getting paid $50K. So 60 plus hours per week, making, let's say, $60K for 4 more years. So for 4 years, like a psych residency is 4 years. And now let's say we compare that to an NP or a PA who might be working 40 hours a week and getting paid $120K, $150K, $200K. So that's the difference. And this is why I've noticed this along a lot of trainees, like especially residents, because they're like, I put in all this work, I put in all this effort, yet an NP or a PA who has a fraction of my training is working less and making way more than I am. So of course, like, and even I felt some of this too, especially when I was in training. Now that I'm out of training, of course, things, you know, I don't feel that way anymore. But it's a natural thing to feel that. And if you weren't aware of this, and now you are aware, so that's where that can be stemming from as well too. And then the next thing that you may not have thought about is physicians feel some form of identity theft. So if you think about it, 50, 100 years ago, the only doctor around was like the medical doctor. Like that's who you call doctors. You don't call PhDs really doctors, or clinical pharmacist doctors, or now like doctor of physical therapy. And now we have, right, DNPs, doctors of nursing practice. So all these people are going around calling themselves doctors. So the title of doctor, the ideal of doctor, the job of doctor, the role of a physician has lost its luster, its sexiness. And so a lot of physicians really lament that. Like nowadays, everyone can go around wearing a white coat. White coats for all. I remember when I was in the hospital, we would see like dietitians wearing white coats and social workers wearing white coats. And one of my co-residents was like, wow, so it looks like they just give it out to anyone these days. And in fact, you might have noticed the movement where a lot of doctors, like residents and attendings, they don't wear white coats because now it doesn't have that special luster feeling. You know, call it egotistical or whatever you will. The point is that like this is a real reason why doctors do not like NPs. The next one is scope creep. So what does this mean? So scope creep, what this means is basically doctors are worried that they will lose their jobs. Because of how many NPs are flooding into the market, they're worried that there's going to be less jobs for them and that they will get outside or laid off or neglected, because if an NP is willing to take the same job for 200K, why should a psychiatrist take it for 250 or 300? Or like, why would it be offered to the psychiatrist for that much? So this is a fear that people have as well too. So you see how all these things stack. So if they're scared of their job, losing their jobs, there's, you know, they feel that, okay, NPs are becoming doctors. They're burnt out and resentment from all the long hours of training that they had to do compared to the NP. And then just like, yeah, the less training in general, all these things start to stack up. So what does this lead to? This is what leads to the hostility, the negativity. Like now as an NP educator, I'm a physician who educates NPs. I get DMs that are like, you're a disgrace to the profession. You know, you should be teaching residents. You know, like take this guy's license away, like stuff like that. So I've received those comments too. And then, you know, on TikTok as a social media creator, I see all the time, like I get these NP hate videos from like on the physician side, or I'll see like comments where they're like, there's like argument going back and forth. There's a whole doctor subreddit, which is called Not a Doctor, and it's specifically targeted towards NPs. Fun fact, I actually got banned from that subreddit because they found out that I'm supporting NPs, but that's a separate story. So now, right, this is why doctors hate NPs. So what is my take on this? So my view for physicians has been, you should just go outside and touch grass. What does this mean? So if you look outside right now, there are more than enough patients. There's more than enough patients out there. In fact, let me just show you. So if I look outside right now, right, like you just look outside, more than enough patients for all of us to thrive, and more than enough patients for all of us to be successful. Like there's a mental health shortage out there, which means that the number of providers is much less than the number of mental health patients who need mental health services, much less. So it may be a little bit more challenging to find roles, or you might have to do your own thing like private practice. But there's more than enough opportunity for all of us out there. This is what's called an abundance mentality, not a scarcity mentality. And I think that if physicians are able to adopt this, this will help them a lot. So Next, I think, is also recognizing that it's not their fault. So it's not an NP's fault that that their training system is set up to steal their money without actually teaching them real world psych. It's not their fault that residents have to work all these extra hours. It's not their fault that this whole field of NPs have come out. They're just taking as an NP, you're just taking the opportunity that's offered to you. If I was a nurse and, this opportunity to become a provider and I wanted to learn more providing skill set, I would 100% take that. I wouldn't be like, oh yeah, I'm going to go to med school and take all my prereqs. No, I'd follow the nice, easy path, the easier path that's laid out for me, the simpler path that's laid out for me. So like I would do the same thing too. Obviously I can acknowledge that, okay, the pro training is something that exists, but you don't know that until you go through it, and then you realize it. And next is that, recognizing that the physicians, or just like in any company, as people rise up, you become more of a manager rather than doing the actual job. So let's say you're an engineer, first you're doing the engineering, then you might have a whole team of engineers working under you. So it's the same thing with physicians. So NPs can work under physicians a lot of times too, and then really provide that collaborative role. They can take on some of the less stressful or the less medically complex patients. NPs can also fill in many roles like community mental health, substance use, detox, rehab. So some of these like rural jobs, some of these traditional jobs that physicians don't want to take, that I don't want to take, NPs can take them. So that way those patients can get care as well too. And in fact, like in our coaching program, we have NPs who work in eating disorder, they work in community mental health, they work in substance abuse rehab. There's so many different areas that NPs work under. And that's an advantage that I don't see that of NPs that people don't really talk about. And then I think lastly is that where I think the field is going to go is it's going to go towards managed care. So rather than like doctors and NPs working the same role, just like we've seen with CRNAs, and now the anesthesiologist takes on more of a supervisory role for CRNAs doing anesthesia, right, intervening when they need to. That's how I see similar for psychiatrists and psych NPs too. So that way we all can have a share of the pie. We all can, all of us can have good jobs. We can all make good money, and we can all help our patients. And so I think that's the view that I would want physicians to be able to take on. But I just wanted to highlight this because if you've ever experienced this, here's some of the reasons why. And if you want to learn more real world psychiatry, especially from a board certified psychiatrist, I would recommend joining our PMHNP Academy. But otherwise, yeah, leave a comment if you've noticed this type of behavior like in your own life or a friend's life, and I'll see you in the next video.